How's it going, guys? Past level question for Pharm. 34-year-old woman, no vignette on purpose because we want you to get this based on the images. The left image showing you the trophozoites of giardia lamblia, this pink image here. And then this image on the right is showing us the cyst. USMLE will show you either image. You need to know both of these are giardia. So giardia is a protozoan, which means unicellular eukaryote, and it causes steatorrhea, so fatty, floaty stools, and it's acquired by fresh water. Okay, so swimming in a freshwater lake in the wilderness. USMLE can say scuba diving. So the implication being it doesn't have to be scuba diving in the oceans. Someone probably scuba diving in a freshwater lake, but water exposure in the wilderness followed by steatorrhea, that's giardia. Okay, and USMLE will show you either image here. So what's the most appropriate pharmacotherapy and its mechanism of action? Should I say 30S inhibitor is wrong? Refers to the aminoglycosides such as gentamicin, tobramycin, amikacin, as well as the tetracycline antibiotics like doxy. So the aminoglycosides such as gentamicin, classically paired with vancomycin as a pyrrhic treatment for endocarditis. Gentamicin targets gram-negative rods. Vancomycin targets gram-positives such as MRSA. Gentamicin also classically combined with ampicillin, so you'll hear amp and gent for a variety of things, for sepsis, for instance. Now, tetracyclines, doxy, Rocky Mountain spotted fever, Lyme disease, two of the highest yield use cases. You need to know the aminoglycosides cause nephrotoxicity, in other words, acute tubular necrosis, and ototoxicity. And then the tetracycline antibiotics like doxy cause photosensitivity in adults, tooth discoloration in children. Point is, wrong fucking answer. Choice B, 50S inhibitor is wrong. Could be the macrolides like azithromycin. Could be chloramphenicol, clindamycin, linezolid. So macrolides, azithromycin, high yield first line treatment for community acquired pneumonia. You can also use doxy, but USMLE likes azithromycin. And macrolides can cause GI disturbance, so a bit of an upset stomach, constipation, diarrhea. You also use macrolides like azithro for chlamydia, so the atypical. So not just for pneumonias, but you can give for chlamydia, for urethritis, high yield. And clindamycin is anaerobes above the diaphragm, so pulmonary abscess. Chloramphenicol, you don't need to worry about the use case. You can use it for meningitis, but it causes gray baby syndrome. Linezolid, lower yield. Point is, wrong fucking answer. Choice C, dihydrofolate reductase inhibitor is wrong. So that can refer to methotrexate, chemotherapeutic agent, DMARD for rheumatoid arthritis. You can also use it systemically for psoriasis. You can give trimethoprim. That's a dihydrofolate reductase inhibitor. Pyrimethamine. Okay, pyrimethamine is used for the treatment of toxoplasmosis, sulfadiazine pyrimethamine. Trimethoprim can be used for simple UTIs like trimethoprim sulfamethoxazole, that combo. Wrong fucking answer. Choice D, DNA gyrase inhibitor is wrong. So DNA gyrase refers to prokaryotic topoisomerase 2. Okay, so that's fluoroquinolone antibiotics, i.e. ciprofloxacin. Okay, so pyelonephritis, prostatitis, the two highest yield use cases for USMLE. You can combine a fluoroquinolone with metronidazole for the treatment of diverticulitis, and levofloxacin is known as a respiratory fluoroquinolone. It has good pulmonary parenchymal penetration. So Achilles tendinopathy is your high yield adverse effect of fluoroquinolones. Point is, wrong fucking answer. Choice E, forms toxic metabolites that damage DNA. Correct answer, it's metronidazole. So you need to know metronidazole treats GAP on the metro is your high yield mnemonic. So G, giardia. E, entamoeba histolytica. T, trichomonas vaginalis, so trichomoniasis. The second G is bacterial vaginosis, so Gardnerella vaginalis. A is anaerobes below the diaphragm, like diverticulitis, as we just said, combined metro with a fluoroquinolone like ciprofloxacin, and we said clindamycin was anaerobes above the diaphragm, pulmonary abscess. And then P is pylori, second line for H. pylori. So when you treat H. pylori, you're going to do CAP, CAP, clarithromycin, which is the macrolide, amoxicillin proton pump inhibitor, CAP. And if that regimen doesn't work, you can substitute out those antibiotics, give metronidazole, tetracycline, bismuth. Correct answer.